So I'm going to be giving you an overview for the boards and focusing on sort of three broad topics, some of which have been covered in previous talks, but I hope it will be sort of a good overview and way of thinking about some of the issues using some cases as examples. I put a lot of animation in this talk, and the reason is it's Friday. And I know everybody's tired, so hopefully the animation will help keep everyone awake. Okay, so let's see here. Okay, so we'll have some clinical vignettes. We'll focus on three sort of broad areas: survival and adequacy, sort of related to the first talk that I gave. Then we'll focus on some dialysis complications, then a specific case of bone disease, which I hope you'll find interesting. So first, let's talk about survival and adequacy. And I'll present this case, which was a case that we had about 10 years ago at Brigham and Women's Hospital. This is a 67-year-old woman with end-stage renal disease on hemodialysis for 3 years, was admitted to the hospital with progressive dyspnea and chest pressure, 3 to 4 weeks duration. She reported a low-grade fever at home 2 days prior to admission. She had no associated chills, cough, night sweats, or weight loss. Her history was that she had been on hemodialysis for 3 years after having had a thrombotic microangiopathy. She had had numerous clotted AV accesses, tunnel catheter infections. She's currently dialyzing with a tunnel catheter for 3 hours, and her most recent URR was about 62%. She also had a history of non-Hodgkin's lymphoma, cardiomyopathy secondary to doxorubicin, hypertension, and metastatic breast cancer. On examination, she had a blood pressure 115/75. She had clear lungs. She had no pericardial friction rub, no pulses. Potassium was 4.5. BUN's 30, creatinine 3.7. Her albumin was low at 2.5, and her ferritin was markedly elevated. So on imaging, she had a chest X-ray, which shows this sort of wide heart. And on echocardiogram, she had a very clear pericardial effusion. So the questions we should think about are, one, what's the cause of pericardial effusion? And two, what are the next steps in her management? So on the first hospital day, she received dialysis with a dry weight challenge, which she tolerated well. However, on the second day, she became hypotensive. She responded to intravenous fluids. A follow-up echocardiogram showed that the pericardial effusion was increasing in size, and she had mild diastolic inversion of the right ventricular wall with no tamponade. She then underwent pericardiosynthesis and had a pigtail catheter placed. The pericardial fluid analysis showed the cytology was negative for malignant cells, cultures were negative, and the adenosine deaminase was unremarkable. So this patient has myriad problems, but what I want you to really focus on is that our dialysis patients have decreased survival, and their survival really is close to that, between that of patients with colon cancer and lung cancer. So there are a number of reasons that dialysis patients have high mortality. The most common causes of death in our end-stage renal disease patients are cardiovascular disease and infection. But there are other things. Many of our patients have significant comorbidities, including diabetes. There is lower overall survival in our diabetic patients. There is either silent or clinically significant coronary disease and left ventricular hypertrophy. And there are a number of reasons for this. It could be, again, related to those comorbidities, diabetes. But they're hypertensive and often will have stiff left ventricles. The metabolic abnormalities, as Dr. Bushinsky talked about, left ventricular hypertrophy with anemia and hyperlipidemia. But there are other risk factors that may be relevant. Their underlying renal disease, the age, where they're dialyzing, race, nutrition, inflammation, anemia, adequacy of dialysis, but things like late referral to the nephrologist can also impact later mortality. Fractures, our patients are at increased risk of fractures, and those may also contribute to their mortality. We've already talked about the National Cooperative Dialysis Study and KT/RV, so I won't belabor that point. We've talked about calculating KT/RV. And this is a nomogram that illustrates, again, we were talking about the importance of ultrafiltration in terms of its contribution to convective clearance. And so you can see that that's illustrated in this graph, that the more ultrafiltration, the greater the amount of convective clearance one gets. Again, we talked about the hemodialysis, the hemo study, and we know that the patients who were randomized to the high-dose arm really didn't have any better outcomes than the patients who were randomized to the standard dose arm. You saw this graph in my prior talk showing that time may be important, that patients who are dialyzing for 4 hours tend to have better outcomes than patients who are dialyzing for shorter periods of time. So independent of urea reduction ratio, a longer time may be beneficial. We've also learned that there may be better outcomes with more frequent dialysis in terms of left ventricular mass. The patients who are dialyzing more frequently tended to have better outcomes in terms of reduction in left ventricular mass, another important marker of cardiovascular disease. Kadoki suggests that if the GFR is less than 2, one aimed for a single pool KTRV of 1.2 or 65% URR as the minimally adequate dose, and the target recommended dose of 1.4 or 70%. If below target, think about the fistula, treatment time, blood flow, and dialysate flow rate. So in our patient, remember that this patient is dialyzing for a relatively short period of time, 3 hours. Her URR was low, and she's got markers of anemia, of malnutrition and inflammation with a low serum albumin and a high ferritin. Second case that I'd like for us to think about is this patient who presented to our hospital about 5 years ago. This is a 48-year-old woman who was on vacation on the Cape, receiving routine dialysis at a local dialysis unit. She had end-stage renal disease from adult autosomal dominant polycystic kidney disease, and it had been on hemodialysis for about 2 years. A polysulfone dialyzer was used, and about 5 minutes into the session, she complained of severe dyspnea, chest tightness, and back pain. Her pulse increased from 70 to 125, and her blood pressure fell from 130/70 to 80/50. She became tachypneic with diffuse wheezing. Dialysis was discontinued without returning blood from the circuit. And you can see her hemoglobin was 9.3, electrolytes were normal, white blood cell count pretty unremarkable. She had a sinus tachycardia, and a clear chest X-ray. She was given supportive management with normal saline, oxygen, and her symptoms resolved over the next half hour. So things we can think about, which of the following are likely explanations for the patient's symptoms? Is it dialysis-associated autonomic dysfunction? Is it an air embolus? Is it a pulmonary embolus? Is it a first-use syndrome or a dialyzer reaction, another way of thinking about it, or a pyrogen reaction? So this is really the case of a first-use syndrome, or another way of phrasing it as a type B dialyzer reaction. An air embolus is not consistent with this presentation. Pulmonary embolus, unlikely in this setting. And we'll talk specifically about what pyrogen reactions are and how they present. So some of the complications of hemodialysis may include hypotension or hypertension, dialyzer reactions, infections, and pyrogen reactions, air embolism, bleeding from the vascular access, seizures on dialysis, hemolysis, arrhythmias, and muscle cramping. Probably one of the most common ones that you'll deal with is hypotension during hemodialysis, so we'll talk specifically about this one. So there are a number of potential causes for intradialytic hypotension. Medications, so what did the patient receive prior to the treatment? Is there autonomic dysfunction? Remember, a lot of our patients are diabetic and therefore at high risk for autonomic dysfunction. Could there be unrecognized sepsis? Our dialysis patients may overproduce endogenous vasodilators like nitric oxide. We may have underestimated the true dry weight, so our ultrafiltration goal may be too aggressive. As we talked about with the previous case, most of our patients have some form of heart disease. They may have reduced diastolic filling due to either atrial fibrillation, tachycardia, or simply left ventricular hypertrophy. There may be ischemia, And as in the last case, pericardial effusions are also something you have to think about in patients who are hypotensive. So these are some of the strategies that I have learned over the years and was taught when I was a fellow. So one of the important ones is to think about what goes in and therefore how much fluid you're trying to take off. So by limiting fluid gains, by limiting salt intake, you can prevent intradialytic hypotension because the ultrafiltration goals will be lower. Increasing the treatment time means that the amount of fluid per unit time being removed will be decreased. Increasing the dialysate sodium may help with hypotension and cramping, but has kind of fallen out of favor because of the idea that we are actually putting our patients in a positive sodium balance. Reassessing and raising the dry weight if necessary. Lowering the dialysate temperature, very effective. Administering drugs that may help to raise the blood pressure, like Metadrin. Eating during dialysis is very controversial. When I was a fellow, our patients were never allowed to eat because of the concerns about hypotension. However, there is increasing evidence, particularly in Europe, where patients are allowed to eat, and we're also very concerned about malnutrition. So I'm beginning to change my thinking about allowing patients to eat during dialysis. And then finally, some people have suggested that L-Carnitine may be effective in helping to reduce hypotensive events. Things that are not really effective, supplemental oxygen, isolated ultrafiltration, and I'll show you some data regarding that. Fludrocortisone, decreases in dialysis machine blood flow rate, probably not very effective. And online hematocrit monitoring, which I'll also show you some data about. So Metadrin is a medication that many of our patients are taking. It's an oral alpha-1 adrenergic agonist. It's highly selective, has no beta-1 activity. The peak level of the active metabolite is achieved about 90 minutes after the drug is given. And among patients with autonomic dysfunction, the toxicities may include urinary retention and supine hypertension. L-Carnitine supplementation, some people have thought may be effective in reducing hypotensive events. Carnitine deficiency is common in hemodialysis patients. It facilitates fatty acid entrance into the mitochondria and acts as a cofactor for fatty acid utilization. There was a randomized placebo-controlled trial of 82 patients that showed some reduction in intradialytic hypotension that was published in KI in 1990. The mechanism underlying this effect is not known. So this was touted in some series to be effective. However, I've never seen it used clinically as a treatment for hypotension, but because it's out there in the literature, I thought I would bring it up. What about sodium modeling? Well, the idea is that as you remove solutes from the extracellular compartment, the plasma osmolality will fall. Plasma osmolality decreases relative to the intracellular compartment, and so fluid is moving into the intracellular compartment at the same time that it's been removed from the vascular compartment. Sodium modeling, therefore, helps to maintain the plasma osmolality as ultrafiltration takes place. And you can gradually change the plasma osmolality. Machines will allow you to do it in either a linear fashion or a stepwise fashion. So again, this is one of the things that our thinking about has evolved over time. About 20 years ago, when I was a fellow, it was a fairly popular maneuver. But as we've become more concerned about the effects of positive sodium balance on perpetuating weight gain, I think that sodium modeling has gradually fallen out of favor. Cool temperature dialysis is a very effective strategy. It induces vasoconstriction, which helps to maintain the blood pressure. The disadvantage is that patients may complain of feeling cold, and our patients are already often complaining of being cold, and you cool them down, they may be unable to tolerate it. However, I'll show you some data that shows that it's a very effective strategy. Sequential ultrafiltration followed by hemodialysis is something, again, that I was taught when I was a fellow. The nurses will often refer to it simply as sequential. The idea is that the isolated ultrafiltration component is isoosmotic and is therefore less likely to lead to hypotension. You can then perform isovolemic hemodialysis after doing the isolated ultrafiltration. The disadvantage is that to get the same amount of dialysis, you're going to have to increase the total treatment time. So I told you that there are some data about intradialytic blood volume monitoring. The only published study that I'm aware of is this study that was published in JASN in 2005. And it was looking at crit line monitoring. And these are devices that prospectively monitor blood volume and have been advocated for better volume management. Crit line is one such device. And the study was the CLIMB study, and it compared conventional monitoring to crit line monitoring to test the hypothesis that crit line monitoring would decrease morbidity associated with ultrafiltration. Interestingly, there was no difference in hypotensive events between the two groups, and actually there's a higher mortality and hospitalization rate in the crit line group, which I find hard to explain, but these are the data. That having been said, online blood volume monitoring is often used in hospitals. One of our institutions had the devices until they were no longer able to get the equipment to use them. So, which of these treatment strategies actually works the best? And this is a nice little study that was published in KI a few years ago. It was a single center study looking at 10 stable chronic outpatients. Single-blinded crossover study design looking at 5 different protocols. A fixed high sodium dialysate, sodium modeling going from 152 down to 140 in the last half hour, sequential, an hour of isolated UF followed by 3 hours of isovolemic dialysis, cool temperature dialysis, or a fixed standard dialysate sodium of 138. And what you can see is that 3 of these strategies, the fixed high sodium, sodium modeling, and cool temperature, were all effective in reducing the number of hypotensive events. To my surprise, in this group of patients, sequential ultrafiltration was not effective in reducing hypotensive events. That having been said, in my ICU patients in whom I'm trying to do conventional hemodialysis, I still use this strategy, but at least in this group of outpatients, it didn't work as effectively as the other treatment strategies. Okay, let's move on to talk about other complications, chest pain during dialysis. So there are, again, a number of causes of chest pain. Chest pain is one of those manifestations that can occur from many different causes. So obviously one has to think about myocardial ischemia or myocardial infarction. Hemolysis can be associated with chest pain, dialyzer reactions, and finally air embolism and pulmonary thromboembolism may also be associated with chest pain. So let's talk specifically about hemolysis. Because it's one of those questions that you may get on your board examination. Fortunately, I've never seen a case in my practice, but I've read about it, and fortunately, it's rare. So our current equipment has a number of mechanisms that are built in to help us prevent hemolysis from occurring. The manifestations may include chest pain or chest tightness, back pain, dyspnea. You'll see the potassium rise, particularly if you infuse that hemolyzed blood back, a fall in the hematocrit. And in the venous lines, the blood will have this port wine appearance. If you centrifuge it, the plasma will have this pink color to it. The causes of hemolysis may include hypotonic or overheated dialysate. I always teach the fellows to remember the 3 C's for hemolysis: copper, chlorine, and chloramines. But in addition, things like formaldehyde, hydrogen peroxide, bleach, or nitrates may also cause hemolysis. And finally, blood pump malfunction or defective tubing may be associated with hemolysis. Fortunately, our dialysis equipment has mechanisms that are designed to prevent these complications from happening. There are temperature sensors that keep overheated dialysate from reaching the patient, and there are conductivity sensors that prevent hypoosmolar dialysate from reaching the patient. What about dialyzer reactions? So these are a broad group of events that may have multiple potential etiologies. The type A reactions are a little bit less common, but think type A for anaphylactic. They typically will occur early in the treatment, usually within the first 15 to 20 minutes. One of the more frequent causes with ethylene oxide was and still is used as a sterilant in some dialyzers. But these reactions are less frequent now because there's been better removal of the ETO from the dialyzers. Furthermore, we have more dialyzers that are gamma sterilized and so don't have ETO in them. The type B reactions, also known as first use reactions, are milder and are thought to be related to complement activation. They may occur anytime during dialysis, but usually within the first hour, and they manifest themselves with nonspecific symptoms that often include back pain and chest pain. So for a type A reaction, you want to stop dialysis and treat like you would with any anaphylactic type reaction: steroids, vasodilators, antihistamines. Subsequently, think about increasing the volume of saline for dialyzer rinsing. If you're using an ETO sterilized dialyzer, think about using a dialyzer that's sterilized by some other method. Use a biocompatible membrane. Switch to heparin type. And remember to avoid the combination of polyacrylonitrile dialyzers and ACE inhibitors. This is a favorite board's question, although it's probably a moot point because these PAN dialyzers I don't think are available in the United States anymore, but there is a very specific reaction that's associated with the PAN dialyzers because of their association with decreasing the breakdown of bradykinin. Type B reactions are a little bit different. They're milder. You can usually continue the dialysis if you can ride the patient through with supportive care. Things like oxygen, saline, Benadryl may often be used. Subsequently, think about using a more biocompatible membrane. And interestingly, if you're in a reuse program, reuse would often make the symptoms abate. And the reason is that the dialyzer becomes coated with the patient's own plasma proteins, and so on subsequent treatments, the patients were less likely to have this type of reaction. So we think this is what our patient had, was a type B dialyzer reaction or first use syndrome. Some of the other complications that we talked about are air embolism. Again, this is one that I've not seen, but you need to be aware of them. They are rare. Multiple potential sites for air to enter the circuit. The manifestations depend upon the patient's position. So in the supine position, there may be dyspnea, chest pain, and hypotension. Upright, patients are more likely to lose consciousness or to seize. And then when they're in Trendelenburg, lower extremity ischemia. On auscultation, you'll hear this churning sound, and you may see foaming of blood in the venous line. In cases of air embolism, you want to clamp the venous line and turn off the blood pump. Position the patient on the left side, chest and head down, give 100% oxygen. And in severe cases, there are reports of air aspiration from the ventricle. Pulmonary embolism is not really a dialysis-associated complication and is not particularly likely to occur during the dialysis session. But again, one of the things that I was taught when I was a fellow was that patients with end-stage renal disease are not likely to develop pulmonary emboli. But that doesn't appear to be true in the current era, and there are some data from ESRD that show actually that there may be actually a greater incidence of pulmonary emboli in patients with ESRD than in the general population. Okay, so let's move on and talk about fever as a complication of the dialysis treatment. So pyrogen reactions may occur during dialysis. Pyrogen reactions are not due to an actual bacteremia, but are due to lipopolysaccharides that are released typically from gram-negative bacteria. Patient may be afebrile pre-dialysis, but develop a fever during the dialysis treatment. Blood cultures usually are negative and no specific infection is identified. And they're more common with high-flux dialyzers, again, because it's easier for these lipopolysaccharides to cross with a high-flux dialyzer. There have been several outbreaks of pyrogen reactions that have been reported in the dialysis literature. There are many possible sources. These include inadequate disinfection of dialysis machines, defects in the water processing system, problems with the bicarbonate concentrate, problems with reuse, and finally, mishandling of intravenous medications. So some of these reactions that have been reported as outbreaks in the New England Journal, They reported a series of patients who developed pyrogen reactions and bacteremia actually associated with serratia liquefactions. And what happened was that in this particular dialysis unit, they were reusing single-dose vials of epogen, which did not contain the preservative. And so in addition to the vials of epogen being contaminated, their hand soap was contaminated. They had multiple sites of contamination. So once they eliminated the process of reusing those single-dose vials with multiple patients, they were able to eliminate that source of contamination. There have also been reports of gram-negative bacteremia in hemodialysis patients that were traced to hemodialysis machine waste drain ports. And there have also been outbreaks that were reported related to contaminated O-rings and reprocessed dialyzers. Now we're going to switch gears and talk about how one deals with hemodialysis catheter management when the catheter is infected. And I know that you've had some comments from Dr. Henschel about this particular issue. But first, it's important to know that catheter-related bacteremia is common, and these are some of the rates of catheter-related bacteremia that have been reported in various studies. The risk factors for catheter-related bacteremia include nasal carriage of Staph aureus, previous bacteremia, patients who have peripheral vascular disease and coronary artery disease may be at higher risk, and diabetes in and of itself may be a risk factor. But other things to think about include patients who have a low albumin and high ferritin, patients who are immunosuppressed, prior bacteremia, poor hygiene, poor catheter care, and anemia may be also associated risk factors. So how do you treat catheter-related bacteremia? Well, I think the first step is antibiotics, broad spectrum, typically for 2 to 3 weeks. Some centers will try to salvage catheters, and there have been various studies of catheter salvage in the literature. One such study reported in the Annals 24 catheters with immediate removal, 38 were left in. Only 12 or 32% of the catheters that left in were salvaged, but there was no increase in complications. Other reports include catheter exchange. If the patient is afebrile at 48 hours and the patient stable without tunnel infection, then you may be able to exchange the catheter over a guide wire. So one approach to thinking about catheter-related bacteremia, any patient who presents with fever and has a catheter should probably be assumed to have catheter-associated bacteremia until proven otherwise. If the patient is clinically stable, not showing signs of sepsis, then you may not need to remove the catheter. If the patient is stable, one of the approaches may be systemic antibiotics with guide wire exchange. Other protocols have included the use of an antibiotic lock rather than guide wire exchange. Okay, so in the last few minutes, I'm going to present a case related to bone disease. And this is actually a real case. So I'll tell you the anecdote about this case. So this is the case of Aunt Lucille. So my aunt was a chronic dialysis patient who had been on dialysis at that point for about 10 years. And she would occasionally call me with, questions or problems related to her dialysis. And I tried not to be too much of the meddling nephew. But this case I thought was a little bit extreme, and so I thought I would present it to you. So she was 80 years old at the time, had been on dialysis for about 10 years, and she was complaining of severe pain in her lower extremities. And her nephrologist had been trying to arrange for her to have lower extremity arteriogram because he thought it was probably related to vascular disease. So she had been on hemodialysis at that point for about 5 years. She had diabetes type 2 with all the usual complications. She had had catheter-related bacteremia with Staph aureus, which had left her with a severe discitis. So she was pretty much wheelchair-bound, and she had known hyperparathyroidism. Her medications included some of the usual suspects on examination. Exam was pretty unremarkable. Her labs were notable for a phosphorus of 5.6, calcium of 11.1, albumin of 3.8. So the question really is, what's the cause of her pain? She had a vascular surgery evaluation, lower extremity arteriogram, but surprisingly, her vasculature was actually pretty good. So what's the cause of her pain? Well, I was a little bit stunned when I learned that her intact PTH returned at 10,317 picograms per ml. And at first I thought, because this was actually the surgeon who was calling me, I said, oh, he's off by a factor of 10, but he wasn't. This was actually what her PTH was. And her alkaline phosphatase was 290. And so the question was, should she undergo parathyroidectomy? Should she be treated with cinacalcet? So Dr. Bashinsky has gone over much of this with you. Maintaining the phosphorus is important. Maintaining the calcium level. We used to think a lot about the calcium phosphorus product, but if we keep the phosphorus well controlled, generally the calcium phosphorus product will be okay. Patients who have severe bone disease are at increased risk for mortality. A retrospective study of greater than 40,000 hemodialysis patients showed the lowest death risk with those with phosphorus between 3 and 5, calcium less than 8, calcium phosphorus product less than 45 to 50, and an intact PTH less than 600. Importantly, we know that phosphorus elevation correlates with increased mortality at baseline and as a time-dependent variable. So Dr. Bashinsky, I'm sure, has talked to you about the various types of bone disease, osteitis fibrosa, PTH-mediated high bone turnover, but we also see adynamic bone disease in which there's low bone turnover. PTH may not be high, but low. And want to think about avoiding calcium-based binders, avoiding active vitamin D, and maybe using lower calcium baths. Or osteomalacia, which is low bone turnover with large amounts of unmineralized osteoid, commonly seen in years past due to aluminum, but since we don't use aluminum as a phosphate binder anymore, we don't see that as often. But you should suspect in dialysis patients with low bone mass and frequent fractures. So the pathogenesis of secondary hyperparathyroidism, you know that phosphate retention occurs, low levels of calcitriol. These lead to secondary hyperparathyroidism. Calcitriol levels tend to fall over the course of chronic kidney disease. You can see that as the GFR falls, the levels of 125 vitamin D go down, and the intact PTH levels rise at the same time. Phosphate restriction may prevent hyperparathyroidism, and you can see that if you can maintain a very low phosphate diet, you may prevent some of the rise in PTH. This is very hard to do, especially with phosphate additives in food, which is why we use phosphate binders. Vitamin D has a number of actions. Calcitriol enhances the gut absorption of both calcium and phosphorus. So when we put patients on active vitamin D, we have to worry not only about the calcium, but also about the phosphorus. It suppresses the PTH and enhances bone resorption of both calcium and phosphorus. Calcium mimetics, on the other hand, simply act to suppress PTH. In terms of treating the phosphorus, dietary phosphate restriction and use binders, and there are varying thoughts on calcium-based versus non-calcium-based binders. I'll leave that to Dr. Bashinsky to talk to you about. Lanthanum is another drug that may be effective in controlling phosphate in several studies, less prone to cause hypercalcemia because there's no calcium in it. As far as we know, no significant adverse events, but there's some concern for the accumulation of lanthanum over time. Other treatments include active vitamin D. We know that some studies have shown that vitamin D improves survival in dialysis patients. Paracalcitol may be better than calcitriol. In the United States, we have 3 commonly prescribed drugs: calcitriol, paracalcitol, and doxorcalciferol, all of which may increase the serum calcium. Calcitriol is effective in lowering the PTH, and you can see that as calcitriol is administered, the PTH will fall, and then when it stops, then the PTH will again begin to rise. Calcimimetics bind to the calcium sensing receptor. 3 prospective phase 3 studies have shown an increased percentage of patients achieving their KDOQI endpoints. A phase 2 study showed reduced risk for parathyroidectomy, fracture, and cardiovascular hospitalization. The major side effects are hypocalcemia and GI side effects. And you can see that cinacalcet is effective in lowering the PTH. The median in this paper was in the New England Journal was about 680. So when you get to PTHs that were as high as the case that I presented, I'm not sure how effective it's going to be. So other treatments for hyperparathyroidism include parathyroidectomy. KDOQI guidelines suggest in cases of severe hyperparathyroidism, when the serum levels are greater than 800 and are associated with hypercalcemia and or hyperphosphatemia, to think about parathyroidectomy. Musculoskeletal complications may include bone pain and fractures. The presenting symptoms in patients who are undergoing parathyroidectomy are mostly skeletal, but interestingly, they often have other symptoms as well, often pruritus, cramping, depression, hypertension being reported. And we know that very high levels of PTH are associated with an increased death risk. So, to summarize, the adequacy of hemodialysis may be measured by KT/V or the urea reduction ratio. KDOQI recommends a target KT/V of 1.4, UR of 70%. Hypotension is a frequent complication of hemodialysis that may be mitigated by a number of maneuvers, including cool temperature dialysate. And I showed you some studies. Hemolysis may be caused by a number of technical problems with the dialysis procedure. Contamination of the dialysate or overheated dialysate are potential causes. Dialysis reactions fall into two types, type A and type B. Type A reactions are anaphylactic, while type B reactions are more nonspecific. Catheter-related bacteremia should be suspected in any patient with fever and a hemodialysis catheter. The gold standard for treatment is removal of the catheter with systemic antibiotics. However, catheter exchange over guide wire may be an acceptable alternative in some circumstances. CKD-MBD is the current nomenclature for bone disease associated with kidney disease. Treatment and preventive measures include dietary phosphate restriction, use of phosphate binders, vitamin D analogs, and calcium mimetic agents. Okay. So we can get ready to use the audience response system. First question, which of the following strategies is least effective in preventing intradialytic hypotension? Is it cool temperature dialysate? Is it sodium modeling? Is it sequential ultrafiltration? Or is it carnitine supplementation? 1 second. One moment, gotta switch over to a. Okay. Let's see what our. So most of you picked the answer C, which I think is probably the best answer. So I showed you data from that trial of 10 stable outpatients who were randomized to different strategies, which included cool temperature dialysate, sodium modeling, sequential ultrafiltration. And in that study, cool temperature dialysate was effective, sodium modeling was effective, sequential ultrafiltration was not effective. Again, there was one study that suggested that carnitine supplementation may be effective in reducing intradialytic hypotension, although I think it is not a very practical tool. Okay, next question. 65-year-old woman with the end-stage renal disease from diabetic nephropathy is admitted to the hospital with chest pain. Within 10 minutes of her first dialysis treatment in the hospital, she complained of itching. She became diaphoretic and short of breath. Her blood pressure was 90/50, and she had diffuse wheezes. Her symptoms and signs are most consistent with A, an acute coronary syndrome, B, pulmonary embolism, C, dialysis-induced pulmonary embolism, D, an air embolism, or E, a type A dialyzer reaction. Okay, great. So just about everybody got the correct answer. This was a type A dialyzer reaction. So this was actually a patient whom I saw about 15 years ago, and she was dialyzing with a particular dialyzer, and I noted in the outpatient unit that she would itch whenever we put her on dialysis. So I switched her to a different dialyzer, a non-polysulfone dialyzer, and she did quite well. She no longer itched. However, when she was admitted to the hospital, that information was not passed on from the dialysis unit, the outpatient unit, to the hospital, and the hospital put her on its standard dialyzer, which was the one that she'd had the allergic reaction to. I happened to walk into the hospital unit and saw her diaphoretic and sweating and being ignored, and realized that she was having a type A dialyzer reaction. And so it's probably one of the more severe type A dialyzer reactions that I've seen. So the correct answer for this one was E, a type A dialyzer reaction. Okay, case 3, or question 3, 38-year-old man with end-stage renal disease of uncertain etiology. He's been dialyzing via a tunnel catheter while his fistula matures. He presents to dialysis with a temperature of 102 degrees Fahrenheit, looks well. There's no purulence at the catheter exit site. Blood cultures are drawn. He's treated empirically with vancomycin and ceftazidime, and the catheter is locked with an antibiotic solution. Blood cultures grow MRSA. At his next dialysis treatment, vanco is administered and ceftaz is discontinued. 72 hours after its initial presentation, he is again febrile with a temperature of 103 degrees Fahrenheit. So at this point, appropriate steps in the management of this patient would include A, removal of the tunnel catheter, B, discontinuing vanco and substituting nafcillin, C, discontinuing the vancomycin, substituting linezolid, or D, ultrasound the AV fistula looking for a fluid collection. So let's see what you think about this one. Okay, so most of you picked the answer that I would choose, which is take the catheter out. So this patient has been on systemic antibiotics, and after 72 hours, he's febrile again. So given the persistent fever suggesting an ongoing infection, I think the catheter should be removed. And the correct answer is therefore A. So the patient has his catheter removed and he's afebrile thereafter. He's prescribed a 3-week course of vancomycin. At the end of his second week of therapy, he remains afebrile but is complaining of debilitating back pain to the point that he can't walk. So the following, which is the most appropriate next step in the management of this patient? A, give him a celecoxib and PT. B, give him a narcotic. C, an MRI. Or D, add gentamicin to his antibiotic regimen. Let's see what you think. Okay. So 100% of you chose the correct answer, which is in this case, doing an MRI of his lumbosacral spine. So back pain and weakness in a patient who has recently been treated for Staph aureus bacteremia is highly concerning for metastatic infections. So we've seen metastatic infections to the spine, we see endocarditis, and you have to be concerned in this case with new back pain and leg weakness that he has a metastatic infection to the spine. And I think that's the last question, so I will stop there.